Over to you, Ashish.
Thank you, Dr. Muruganathan. And I would like to first thank Dr. Anuj Maheshwari, Dr. L. Srinivas Murthy, Dr. Anubha, Dr. Narsingh Verma for inviting me for this conference, important conference. So I'll be talking about IBS, and after Dr. Rajesh Upadhyay, who has set the bar so high, it's very difficult for me to match the level of his lecture. So many physicians give a label of IBS to any chronic intestinal problem once they have ruled out other disease. So if the patient comes with gas, pain abdomen, anything like that, they say that it's just IBS. But this is not IBS. In fact, there's a big lot of GI disorders which are known as functional GI disorders, and IBS is a subset of disorder among the functional GI disorders. So many patients will come with either heartburn, nausea, vomiting, bloating, gas, pain abdomen, constipation, diarrhea. And there are many organic causes for these, including cancer, infection, tuberculosis, IBD, inflammatory bowel disease, peptic ulcer. But once you have ruled out all this and there are no structural abnormalities, then you would label them as functional cause of these symptoms. And then this is called as functional GI disorders. And lately, in last 1 or 2 decades, Rome Foundation was created, which constitutes members from about 27 countries. There are 144 experts, and they have devised various criteria to diagnose these functional GI disorders. So functional GI disorders are now based on these Rome diagnostic criteria. And the Rome criteria actually lists the functional disorders of various organs of GI tract, like there could be a disorder of the esophagus, then gastroduodenal disorders, bowel disorders, then CNS disorders, gallbladder and sphincter of Oddi disorders, and anorectal disorders. And the diseases which represent these disorders, like functional chest pain, functional dyspepsia is the gastroduodenal disorder, then IBS is the representative disorder of functional bowel disease, and similarly there are other diseases as well. But they are not only IBS and functional dyspepsia, there are a host of other diseases which are labeled as functional gastrointestinal disorders. So how common are functional gastrointestinal disorders? In India, the most frequent symptoms of functional disorder is gas. Anytime the patients in any clinic, even be it cardiology clinic or diabetic clinic, most patients will, in addition to complaining of their symptoms, they'll also say that they are having gas and they want to get rid of the gas. So if we see all the disorders starting from esophagus to gastroduodenal disorders, IBS, bowel disorders, many of these disorders have gas as one of the important symptoms. So a global study was conducted where worldwide prevalence of functional GI disorders was conducted, and Dr. Ghoshal and Dr. Nitesh Pratap represented India, and it was found that at least 20 to 40% of population do suffer from some of the other functional GI disorders. And these GI disorders could range from dyspepsia, constipation, IBS, diarrhea, or even just bloating, abdominal bloating, and any other. But most common was constipation, as Dr. Rajesh Upadhyay did mention. Up to 11 to 12% had constipation. And also the IBS was in around 4%. Dyspepsia, or the upper abdominal discomfort, was around 7%. In India, a large study was done on prevalence of IBS, Irritable Bowel Syndrome, and it was found that at least 4 to 7% of population do have Irritable Bowel Syndrome. So what is the pathogenesis of functional GI disorders? Right from the 1950s onwards, people have been trying to discern the pathogenesis of functional GI disorders. And initially it was thought that functional GI disorders are only due to stress and due to brain. But later, other pathogenic disorders came into focus, like meal was considered one of the causes. Then visceral hypersensitivity came. And in last few years, it is being thought as it is a gut-brain axis disorder. So what is gut-brain axis? So in a person who is predisposed in early life, early childhood by abuse or parental beliefs or behaviors or social learning, and they have, if they have genetic disorders, then later in the adulthood, because of various psychological factors, they may develop a disorder known as gut-brain disorder. So they develop visceral hypersensitivity, and in the intestinal, they may have a certain low-grade immune-mediated inflammation, and also there's alteration in the gut mucosa, and there's alteration in the gut microbiome. So all these disorders in the gut, which leads to action back on the brain, is defined as gut-brain disorders. So there is stress or anxiety on the CNS level, and then there's low-grade inflammation in the GIT level, and that can cause these disorders. So brain-gut axis is very important, and because the brain, also there's inhibitory pathway in the spinal canal, and then pain is perceived by the brain. So when there is visceral hypersensitivity in the intestine, it is perceived as severe pain by the brain. So about functional gastrointestinal disorder, they are very common, and up to 40% of the general populations are affected by it. And functional gastrointestinal disorders constitute functional constipation, up to 12%, dyspepsia 7%, diarrhea 5%, IBS 7%, and unspecified 11%. The pathogenesis are multifactorial, especially there is a role of brain-gut axis, abnormal motility, visceral hypersensitivity, psychological factors. Then there's role of gut microbiome, gut inflammation, and increased permeability, bile acids, and CNS processing and gate control theory. Now coming to the IBS. So IBS is basically pain plus altered bowel habit. So in the diagnosis of IBS, the pain is an essential criteria. And usually the patients of IBS will have symptoms of more than 6 months, and following criteria should be fulfilled. Within last 3 months, that there should be recurrent abdominal pain, and the pain should occur almost every week. And along with the pain, at least 2 of the following should be there. Either the pain is related to defecation, or there is a change in frequency of the stool, so they may get diarrhea, or they may get constipation along with the pain, or there's a change in form of the stool. So they would get either loose stools, or they may get lumpy or hard stools. So if there's no pain, then we cannot label as IBS. So for IBS, the pain is the most important symptom. If there's no pain, then we can definitely say that he may be having functional GI disorders, but it is not IBS. So this is a WhatsApp chat which we doctors often receive early in the morning. Doctor, I need help. So when the doctor says, what happened to you? Then he says, I'm having very severe constipation, doctor, in the morning. Then when the doctor asks, how many times are you passing stool? Then the patient replies, I'm passing 3 to 4 times a day. When the doctor asks if you're passing stool 3 to 4 times a day, then why do you say that you are having constipation? Then, and the last he says, pet nahi saaf ho raha. That means he is having incomplete evacuation. This is a very common disorder where, as Dr. Rajesh Upadhyay also mentioned, that the patient's perception of constipation is different from the doctor's definition of constipation. The doctors define constipation according to the well-laid criteria, while the patient, even if he's passing stool 3 to 4 times a day, but if he's not feeling satisfied by passing stool, he'll still say he is having constipation. So to diagnose constipation, a Bristol stool scale is very important, which Dr. Rajesh Upadhyay also mentioned. So the type 1 and type 2, where they are a very separate lump-like stools or sausage-shaped stool, this constitute constipation. Type 3, type 4, and type 5 are normal stool. Type 6, where there's fluffy pieces of stool, and type 7, where there's watery and no solid pieces, these are constitute diarrhea. So all the doctors, all the physicians, you all must have a Bristol stool chart in your clinic, so that once the patient says, I'm having constipation, you can show this stool chart and ask him what type of stool he's passing. So based on a Bristol stool chart, the IBS is divided into either constipation predominant when he's passing type 1 or type 2 stool, or it is diarrhea predominant IBS. when he is passing type 6 or type 7 stool, and sometimes he is having mixed type. Sometimes the patient is passing constipation type 1 or 2, and sometimes type 6. And then there's an unspecified type. So what is the clinical profile of irritable bowel syndrome? This was a large study which was done, published few years ago. Dr. Rajesh Upadhyay was also a part of this study. And the IBS patients were divided into 3 types: constipation predominant, diarrhea predominant, and indeterminate, based on the stool frequency. And it was found that incomplete evacuation, or when the patient says पेट नहीं साफ हो रहा है and he's not able to clear his stools, is common in all 3 types. Even in constipation predominant, diarrhea predominant, indeterminate predominant, at least 80 to 90% of the patients complain of incomplete evacuation. Then the other common symptoms is mucus. The patient says that he's passing a lot of mucus. And then even the patient is having irritable bowel syndrome, which is a disorder of lower GI tract, he still may have, at least in 50% of patients, have upper abdominal discomfort. Then these patients, at least 70-80% have tiredness as their symptoms. So IBS leads to a loss of work and lots of tiredness, inability to, and it can lead to depression as well. So how do we approach to a patient with suspected IBS? So once you've diagnosed the IBS, based on the criteria of Rome 4 criteria, that there is pain, there's alteration in bowel habit, and then pain is related to defecation, then you have to rule out alarm features. Dr. Upadhyay already mentioned these alarm features, like if there is weight loss, if there's blood in stool, if the onset of symptoms is more than 50 years, if there's fever, any family history of colorectal cancer, and if there's lymphadenopathy or if there's anemia. These are alarm features. If we have ruled out, if the alarm features are present, then we have to investigate further, because these patients may have certain serious disorders like GI malignancy. But if they are not there, then very limited laboratory tests are required, like complete blood count, C-reactive protein, fecal calprotectin, and just celiac disease serology. Only these 4 tests are important, and then we can diagnose IBS. And once you have diagnosed IBS, you have to classify it either constipation predominant or diarrhea predominant or the mixed variety based on the Bristol stool chart. So I mentioned about a test called fecal calprotectin. So what is fecal calprotectin? So stool calprotectin is a calcium and zinc binding protein, and it is mainly found in neutrophils, and it is found throughout the body. But if the calprotectin is being excreted in feces, it means there is increased neutrophil migration into the GI tract, and which indicates there's inflammation. So when stool calprotectin is high, then it indicates inflammatory bowel disease, and this is not IBS. So fecal calprotectin is normal, then it is IBS probably, but if it is elevated, then we have to suspect irritable inflammatory bowel disease, or IBD. So how do we treat IBS? So once you have diagnosed IBS, then establish a good doctor-patient relationship, because it's a lifelong disease. So we have to acknowledge that it is a disease, and the patient is not a psychiatric patient, he is not mental or like that, and we have to reassure the patient. We have to educate the patient. And then lifestyle modification is important. We have to increase the fiber intake, we have to decrease the FODMAP diet, increase physical activity, and avoid stress. And according to the classification, IBS-C, that constipation predominant, you have to give for pain. In all 3 categories, you have to give antispasmodics, but in the IBS-C, you have to give osmotic laxative, as Dr. Upadhyay mentioned. For diarrhea predominant, we have to give loperamide. But if it is not effective in the first stage, then you can give other drugs like linaclotide, rifaximin, and cholestyramine. And then you can also add antidepressant. For constipation predominant, you have to add SSRIs, and for mixed type or diarrhea predominant, you have to add tricyclic antidepressant. What are low FODMAP diets? FODMAP means fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. And FODMAP diet leads to high osmotic load, and it leads to high colonic gas production in the setting of visceral hypersensitivity. And multiple studies and meta-analysis have shown that if you give low-fat FODMAP diet, then the patient feels better because the less gas is produced, and so there's less bloating, and so patient feels better, especially those having high visceral hypersensitivity. So they have less of abdominal discomfort. So we must have a low FODMAP diet chart. Like for example, vegetables, certain vegetables are high FODMAP. We must avoid them, like garlic, onions, while lettuce and carrot are low FODMAP. Similarly, fruits, proteins, fats, we can divide them into low FODMAP containing and high FODMAP containing, and we can advise our patients. So IBS is a specific form of functional GI disorders, which is characterized by pain plus altered bowel habit. Apart from pain, altered bowel, many patients also have other functional symptoms such as dyspepsia, bloating, gas, and IBS has 4 subtypes: constipation predominant, diarrhea predominant, undeterminate, and mixed variety. And diagnosis is basically clinical with minimal tests, and treatment, as I mentioned, is mainly symptomatic. Thank you for your patient hearing.